Okay, so this is recording. I'll also post it on the Heritage website and YouTube. I know that there's no objectives yet, but they'll be up soon. I had to make this new PowerPoint from scratch because they couldn't find the older one to kind of pimp off of. So at any rate, we're working on that. But the main thing is I will review this and we will be comfortable with the material that's required. But I'll also be posting some objectives shortly. So infective pulmonary diseases, we really touched a lot on this on the pediatric lecture. Who cares about the PANCE blueprint? Well, you care because you are going to take that test. And I'm just going to keep hammering it into your brain. Here it is. Here's the pulmonary section. You're welcome. I follow this blueprint to make this lecture so that you are well prepared for the test that you will take at the end that will make or break your life. So these are the topics that PANCE cares that you know. These are the topics that we will cover today. So in general, we're going to start out with the first topic that they talk about is bronchiolitis. So bronchiolitis can be defined as inflammation of the bronchioles, just like it sounds. It primarily affects children below the age of 2 years old, primarily infants. They have small little bronchioles, so those small little bronchioles are more likely to get plugged. This term can be used very interchangeably with RSV. It is not necessarily RSV, but RSV is the primary cause of bronchiolitis, and therefore everyone refers to bronchiolitis and RSV interchangeably. Don't be fooled, they are different. Although, since RSV is the main cause of bronchiolitis, many times we use them synonymously. Okay, so also can be caused by parainfluenza, adenoviruses, rhinoviruses, and coronaviruses. So basically, any virus can cause bronchiolitis, but your primary bad actor is RSV, which is respiratory syncytial virus. When it's caused in the wintertime primarily, but it can be a lot of other times of the year also when you look at the other viruses that cause it. But RSV itself is primarily a winter bug. Clinically, they're going to present like a URI. This is initially, so they can have some wheezing. You might note some crackles because what's happening with those crackles is those small airways have mucus in them, and then when they breathe, they open up and they make that crackling sound like you're pulling apart some Velcro. They may progress to some lower respiratory tract symptoms and develop signs of respiratory distress. Diagnostics for these kiddos is usually based on physical exam findings, as well as probably a chest x-ray. Labs are not going to be high yield, and we would rather not pick on kids if we can help it. However, if they're necessary, we may opt for that, particularly if they're going to be inpatient. So if they're going to be inpatient, you're going to discuss this case with a pediatrician, and you guys will come up with a plan, and you'll want to know what labs he wants before you poke this child so that you don't have to poke them multiple times. Now, don't be fooled. Also, adults can get this infection as well. It is not only children that have RSV infection. Management is largely supportive. So mostly what we do for these children is we cover them for fever if they have it, so they don't end up with a febrile seizure. We're going to educate the parents on exactly what's going on. There is inflammation of your child's lungs. There's a bunch of mucousy, junky fluid in there that is making it more difficult for them to move air. The best way to get rid of this is to hydrate the child so that that thick plugged mucus becomes thinner. So we really want to educate the parents on proper hydration, on what respiratory distress looks like so that they can look at those things on their child and they know that if that occurs, they need to come back to the hospital. Albuterol is also helpful. Albuterol is going to be a bronchodilator. It is going to allow them to have a more obstructive cough. So when they're coughing and coughing and coughing, they may actually produce some sputum to get that crap out of their airway and out into the environment. We want to educate. A cool mist humidifier is the mainstay of treatment. Okay.
Tim, would you suggest honey for the mucus?
Honey.
Yeah.
So if they are more than 1 year old, you can, and that's actually not for mucus, it's for the cough. So it's kind of soothing for their cough because it coats the upper airway and helps them to cough a little bit less. I would suggest that in a child over 1. Under 1, we're concerned about the potential of botulism toxicity, so we don't give honey to children under the age of 1. But yeah, that's a good point. There's also something called Zarbee's, which is it's a derivative of melatonin mixed with honey, and that's really helpful for parents and children at night. Now, we also want to caution parents that they do not use antitussives in children other than the Zarbee's, honey, or some sort of conservative treatment option like Vicks Vapor Rub or a humidifier. The reason is that children cough to protect their airway. So when they're coughing, it's annoying. We hear it all night long, and our parents get really freaked out and they want us to stop that. But the average parent who has a brain, if you educate them that the coughing is the sound of that child protecting their airway. As they cough, that garbage does not go deeper into the lung. So although the coughing is annoying and it makes us worry about the children, what we have to remind parents is, hey, that coughing actually is the sign that your child is protecting themselves from getting pneumonia. If we suppress that cough, we can almost guarantee that they will end up with a pneumonia. So you need to educate parents because there's a lot of over-the-counter junk that they can get. And a lot of it says for under 2, talk to your pediatrician, but sometimes people will still give it. There are some antivirals for high-risk populations like your premature infants. So here's a little thing on RSV from Oxford. So it's just another little visual representation of RSV. It really just kind of touches on the same things that I've talked about. There is a large amount of death worldwide from RSV under the age of 1. Lots of kids are hospitalized each year. Usually their hospitalization results in largely supportive treatment, maybe some positive pressure oxygen, and just making sure that we keep them hydrated with IV fluids. Here's a representation of what they're kind of synonymously saying, oh, bronchiolitis, look, it's RSV. But if you look really in the small print, it says the most common cause is RSV, but also rhinovirus, parainfluenza, and influenza virus. So clinically, this is kind of just the same representation of what I talked about. We want to make sure that they don't get dehydrated, that they don't have apneic episodes, that their oxygen saturation is no less than usually 93 and sometimes 90, depending on your pediatrician. We want to give them anticipatory guidance. We want to teach the parents how to suction them nasally, and we want to make sure that they are hydrated. These bronchodilators are often used mostly because parents need something to give their child, but bronchodilators have been fairly controversial. I don't think there's good evidence to suggest one way or the other. At the very end of this, if they get really, really sick, we've got to tube them, and you don't want to tube a baby if you don't have to. So let's talk about respiratory distress. So what is respiratory distress? Well, these are the things that are respiratory distress. These are the things that we need to look at these children and say, this child is in trouble. I'm worried about this child, and I'm going to take this child seriously, okay? Even if he just has a run-of-the-mill cold, these children can decompensate quickly, particularly if there's signs of respiratory distress. children that are in respiratory distress are not super concerning. To me, it is when they run out of energy. That is when they're in deep doo-doo, because they are working super hard to move air, and eventually they will fatigue out and they will not move as much air. So signs of respiratory distress: breathing rate increases, there can be some grunting, nasal flaring, retractions, sweating, wheezing and stridor, and they may tripod or change their body position. Acute bronchitis. So this is a chest film of acute bronchitis. These are the bronchioles. They are infected and inflamed. So the way that we define this term is inflammation of the bronchus. So in general, 90% of this inflammation, this is a chest x-ray of a viral bronchitis. There is no pneumonia here, not even a parahilar pneumonia. In general, 90% are caused by a viral etiology such as rhinovirus, coronavirus, or RSV. Could also be influenza, defined as inflammation of the upper airway. So the trachea, the bronchi, and the bronchioles. People with chronic disease may be more prone to developing a secondary bacterial etiology, such as Haemophilus influenza, strep pneumo, and Moraxella catarrhalis. The primary pathogen for all secondary infections, as well as primary infections of pneumonia, is Streptococcus pneumoniae. Signs and symptoms of this are going to include cough. There can be sputum. Patients tend to think that if they have yellow or green sputum that they definitely have a bacterial infection. This is not necessarily true. Signs of pneumonia may and can be present, and this would be increased heart rate, fever, chills, things like that. Comorbidities will determine our treatment, and a chest x-ray is also going to be helpful. So if I've got some sick smoker who has COPD, they're going to get started on antibiotics. If I've got a healthy young individual that thinks they're dying and they've had a cough for 2 weeks, I'm going to tell them to eat sand. They're not going to get antibiotics, and I'm going to educate them on why. If you educate your patients, you'll get more buy-in. If they understand why you're not giving them antibiotics and you make a good case for it, then you are more likely to have them agree to the treatment plan and not go seeking alternate means of treatment, which they will. They will walk right out of your clinic and they will walk right into an urgent care and get their antibiotics if you do not adequately educate them on why you are doing what you're doing. My education sounds like this. So you do not have a fever, you do not have an increased heart rate, you do not have an increased breathing rate, you have a bad cough. To me, this sounds like a viral infection. Let me talk about this. 90% of bronchitis is viral. Yes, you do have bronchitis. You do not have bronchitis that requires antibiotics. If I give you antibiotics, it will wipe out your normal bacterial flora. Let's talk about bacterial flora. So bacterial flora is like a nice green grass. It covers all the orifices of your body, like your upper respiratory tract and your vagina. If I give you antibacterials, we will disrupt that nice green grass. We will take a shovel and dig holes in that nice green grass. Just like a nice green grass keeps out weeds and bad actors from growing in the grass, so does your bacterial flora. If you disrupt that bacterial flora, you're actually more likely to get a bacterial infection and or another more virulent virus. So we are protecting you from wiping out your normal flora. This makes you more susceptible to future infection in the future if I give you antibiotics. So come back to me in a couple days if you start getting a fever, if you start getting really short of breath, and we will evaluate for antibiotics. But until this point, At this point, we are going to defer antibiotics and protect your own body. Use some conservative treatment options, maybe even prednisone to decrease inflammation. You do still give them medicine because that's what they came for, but you do not give antibiotics because it's not good for the patient. All right. So if they do have a bacterial pneumonia, you'll see it on chest x-ray if you have that at your disposal. If you don't, you have to go off of vital signs and clinical presentation, plus their past medical history and comorbidities.
So
Management.
Tim, question.
Yes.
What would a chest x-ray, how would it look different from the one above in terms of bacterial versus viral?
Sure. So I'm going to show you some bacterial chest x-rays later, which generally show a lobar consolidation or air bronchogram, which we'll talk about. But this x-ray is really just showing what they call a viral pattern. So we have definitely some inflammation in the bronchioles and upper airways. Let's see if I can get my little thing going here. Ah, crap. Oh man. I just want to draw on here. Anyway, it's not going to let me draw. Oh, here we go. Okay, now I can draw. Okay, so your airways here, right? There's the trachea. You can see the trachea on this patient right here, trachea. And then you branch into the two separate lungs, okay? Then you have your bronchi and bronchioles that kind of flare out through this part, okay? If this is a bronchitis that's probably viral, it's going to look like this. If they're developing a bronchial pneumonia, it's going to be based on this, will be a little bit darker. You may see some what they call air bronchograms, and the patient's presentation is going to be different, meaning that that patient is going to be sick as stink if they have a bronchitis that is a bacterial origin. And remember, 1 out of 10 patients will have a bacterial origin. So what we generally do is, if this is some sick patient, we may just put them on antibiotics because we're not 100% sure. That's one thing we always have to know. You're not 100% sure that this is not bacterial. It could be at the early stages of bacterial. Eventually, they'll form a parahilar pneumonia maybe, which will look like this. You'll have a whiteout here and here, or they'll develop a lobar pneumonia where the entire lobe is full of consolidation. So we'll cover that a little bit more in depth, but that's something that just takes time. I recommend doing the Radiopedia radiology program through them. That's a really good way to learn radiology while in PA school so that you don't feel like an idiot when you go into your ER rotations. So empiric treatment for chronic bronchitis. So these are our, yes.
Can you repeat that one more time?
Oh, the Radiopedia thing?
Yeah.
Yeah, so Radiopedia, if you look it up online, it's got courses. And I think most, there might be some, I think there's free courses for students. If you say, hey, I'm a, broke student, they'll enroll you into a free course, and you can do, they're really cool. They've got lectures like this, and then they show you radiographs, and they walk you through them. Huh? Yeah, for sure. And they're really cool. And there's also some YouTube like series on there for reading chest radiographs. And what I'll do is maybe this afternoon, I'll put some of those up. And you don't have to necessarily do them like before the test, because that probably not going to be really high yield for you. But at least it would show you how to get to them. And then, you know, maybe like in December when you're chilling, you could like go through that. I went through that a couple times. So I'll put the one up that I used, and it's just really nice. It's like, okay, the physics of radiology. What am I looking at? What's this? What's that? You see the structures. You can tell if it's a good x-ray, if it's bad x-ray, if the patient's rotated, if it's an AP or a PA film, if it, you know, all that kind of stuff, you know, what certain wires are and where things are going, and all that's just really, really confusing. And it's not really helpful. The little bit that we do in school, you really have to just dive into it. The second thing about PA school is that there's so much to cover so fast that there's so many areas that you look at and say, geez, I wish I could like go into that more, but I just don't have time. And that's where we're a little bit different from physicians in the fact that we don't get to dive into things so deeply. It's not that it's not that we don't want to or we're not interested. It's just that our school is so quick and so fast that you have to cover the really high yield stuff, and then later you have to go back, and it really is one of those jobs where you continually keep learning. So Radiopedia for the short answer.
Thank you.
Welcome. Okay, so empiric treatment for some of these chronic bronchitis people. So, you know, chronic bronchitis, emphysema, bad asthma, maybe patients with lung problems, immunocompromised people that you are like, hey, you know, this person has bronchitis. Yes, 90% is viral, but those 10% of the people that we want to treat. So like, even if these people don't have a fever, don't have chills, don't have those findings, they are still going to be treated prophylactically. So a second generation cephalosporin is the primary choice, and a second generation macrolide or trimethoprim sulfamethoxazole is your second line choice. So here's the kind of comparison of your cephalosporins. So you've got your first generation, which is like your Keflex, and then your second generation, which is really cefoxetine is the one that I've seen. And then third generation is your ceftriaxones. And then cefepime is fourth generation, and I've only seen that with kids with ear infections, but you don't see it a whole lot. Macrolides, so we talked about a second generation macrolide. So your second generation macrolides is going to be Cipro. But a lot of times with these guys, I probably break the rule. I go straight for Levo. It's just one time a day and it kicks butt. So I usually will use Levo. Other indications for antibiotics would be elderly patients. So what's the age of elderly, right? 65 plus. So just think of it this way. If they've got Medicare, then you might treat them a little bit more delicately than others. Underlying cardiopulmonary disease. So if somebody has heart problems, not just like benign hypertension, but they've got some congenital heart abnormality or some real badness in their heart, you may want to prophylactically treat them, right? They are not getting oxygen and nutrients and moving waste products out of their lungs very well. So they're going to pool that pathogen down there longer and more likely to create a bacterial infection behind that mucus and gunk. So we kind of want to be extra careful with those people. People with a cough for more than 10 days that are considered immunocompromised, which is a huge amount of the population that we need to kind of be suspicious of, right? These are people that maybe have rheumatoid arthritis, they're on methotrexate. We'll go through a list of what immunocompromised means in a sec here. but not your healthy young adult, okay? They've got a virus. They want antibiotics because they think it'll make them better, but we have to educate them because we really are the only line of defense against the viruses and bacteria becoming completely immune to our antibiotics. So we're creating a lot of bacterial resistance because of the way we prescribe antibiotics. I will say this too. The more trust that you develop with your patients, the more likely they are to trust you and to listen to what you say. So listening to your patients, caring about your patients, and developing a relationship with your patient will help you to have them trust you when you tell them something that's difficult for them to do or that doesn't agree with their moral norms. So what does immunocompromise mean? Well, immunocompromise can be a whole bunch of stuff, right? It can be congenital conditions, syndromes, B cell defects, combined T and B cell defects, macrophage problems, some problem with their function. So cancer patients, people with sickle cell, people with complement deficiencies, end-stage renal disease, right? Because you're going to lose all of your complement proteins, people that are malnutrition, HIV infection, trauma, your chronic drug abusers, people with cancer, and people that are on immunosuppression. Epiglottitis. So epiglottitis is a severe infection. It comes on really fast and it will kill you dead. Can be caused by viruses and bacteria. Who gets it? Well, all ages get it. The most common age is actually in kiddos. And then in adults, it was like between 45 and 65. So I kind of average it out around 50, 52, somewhere around there. So usually it's like little kids or middle-aged adults. Haemophilus influenza is the most common cause in kids. However, that has really decreased due to vaccinations, although it's making a comeback from the anti-vaxxers. So most common bacterial causes in adults is group A strep, strep pneumoniae, Haemophilus parainfluenza, and Staph aureus. So this is a really good talking point, I think, for your anti-vaxxers. You know, I always kind of say, hey, look, I'm happy with whatever you choose to do, but you know, I do vaccinate my children, and this is why. There's some scary infections out there that can get a hold of them really quickly, and I've just decided that I'm going to go with vaccinating. I think it's better for the community as a whole, then I choose to do it. But you know, I'm not going to hold any malice against you if you decide not to vaccinate your children. So the clinical presentation of epiglottitis, these children are sick as stink. Okay, look at this kid. That is respiratory distress. Look at the posture. So sudden onset of high fever, they're going to be in respiratory distress. There's probably going to be an inspiratory and expiratory stridor. They're going to have a terrible sore throat and a very muffled voice, okay? That epiglottis is thick. It is inflamed. They cannot move anything past it. There may be drooling, okay? There's not often a time that you see a patient drooling, tripoding, or sitting up with such good posture. They may have a cough and they may not have a cough. So we need to get a lateral neck film on these patients. We're going to do some labs, and we want to stabilize the airway. And then we can worry about the other crap. The biggest point to this is to stabilize the airway. So how do we go about treating this? Well, first we want to stabilize the airway. Then we can get a film if we have time. What we're going to see is this characteristic thumbprint sign. Okay, so the thumbprint sign is this right here. That's all the epiglottis. It's swollen and inflamed, and it does. It looks like somebody just printed their thumb right on there. This is a normal epiglottis, okay? And this is a super inflamed epiglottis. So clinically, we can already diagnose this without this imaging. So that's one thing you want to make sure. So we want to stabilize our patient before we worry about getting the picture. So the management of epiglottitis is one, we need to secure the airway. Okay, second, we definitely need to secure the airway. And third, we should probably secure their airway. All right. So if you think you have an epiglottitis patient in the room, do not examine that child until you get an airway cart and you pick out their tube, because you may be tubing this child quickly. And nobody ever likes to see children die when you're working in the emergency department. So you get your airway cart and you get your respiratory therapist near the room before you even mess with this kid. The minute you irritate the kid by examining them, they can really go south fast. So they're barely moving air, and then when you irritate them, they're going to go south. Once you've secured the airway, then you can do everything you need to do, but you already know what it is, because generally children don't come in drooling and have that sort of a presentation. You're going to start broad spectrum antibiotics with the second or third generation cephalosporin, and you can also use dexamethasone for inflammation. CROUP. So CROUP is one of those hacky coughs that if you hear it, you will never forget it. Lean on your nurses if you're new to the medical field or you haven't worked in a hospital setting or you haven't heard CROUP before. Your nurse will walk by you and say, oh, that's a croupy cough. Or they'll just flat out say, that kid's got CROUP. And if you don't know that, then you should try to see that sometime in your clinical year. If you hear that cough, you will never forget it. I would recommend going to the internet and listening to that croupy sounding cough. This is also known as laryngeotracheal bronchitis. Primarily occurs from the age of 6 months to 5 years. Causes include parainfluenza, RSV, adenovirus, influenza, coronaviruses, and rhinoviruses. So this is primarily caused by parainfluenza. CROUP is this croupy, barky, seal-like cough. They might have hoarseness. They might not be making very much noise when they talk, aphonia, and they may have a low-grade fever with some rhinorrhea and other URI symptoms. Diagnosing CROUP, well, usually it's just done clinically, but if we would like to take a lateral and a AP film so that we can see that this is not epiglottitis, that it is actually CROUP. CROUP has this great buzzword, the steeple sign, which we're going to see, and we already talked about this in the pediatric lecture, but this is that steepling here, and it definitely correlates to the steeple up there. And so that's the steeple sign. Normally this airway should be nice and open, but when you get that steepling, you've got this inflammation right here that's causing narrowing of that airway, and that's where the stridor comes from. Management of CROUP, well, for mild CROUP, we're just going to support them with hydration. You can use corticosteroids such as dexamethasone. You're definitely going to use corticosteroids even with mild CROUP. I mean, they say here, oh, with mild CROUP, don't do anything. Well, BS. If this kid shows up in my ER, he's getting corticosteroids and he's getting racemic epinephrine no matter how he presents. Okay, because if this kid goes home and decompensates, then every lawyer in the world is going to say, well, why wouldn't you just blah, 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 give him Dex and give him a treatment of racemic epi? Well, they're probably right. If a child is sick enough to be in my ER, they're getting dexamethasone and they're getting racemic epinephrine before they leave, and they're not leaving for 3 to 4 hours. CROUP can change over time, so we want to watch these kids for 3 or 4 hours, particularly after we give the dexamethasone, to make sure that they do not decompensate. The Wesley score is a score that pediatricians use, and so if you do not give them a Wesley score, they will think you're an idiot. So if you get a kid with CROUP, you need to calculate their Wesley score so that they know exactly what type of child they're dealing with. If they've got a sick child, the Wesley score is going to be higher. If they've got a not sick child, it's going to be lower. So we want to use this score so that other professionals know that we are professional and we were educated enough to know that there is something called a Wesley score, and we eventually use up to date when we really have to. So the Wesley score works like this. You grade each of these things being on the right-hand side, level of consciousness, degree of cyanosis, stridor, air entry, and retractions. For each of these, you give them a score and then you calculate the total number. So if their level of consciousness is disoriented, they get a 5, okay? If they are cyanotic with agitation, they get a 4, so now they're a 9 already. And if they get stridor with agitation, then it's a 1, and at rest is a 2. Air entry, we want to see if there's marked or decreased air entry, so that would be wheezing. And if they're retracting or showing any signs of respiratory distress, then we can also give them another number. What all those numbers mean is that symptomatically, we can now talk to the pediatrician on a level playing field, and we can say, hey, I got a kid that's got a Wesley score of 8. I want to admit this kid. And they're going to say, damn, you did your homework. You know about the Wesley score. I'm screwed. I have to admit him, right? So know your Wesley scores. It makes you look like a good professional, and this is how pediatricians will communicate about CROUP severity with a PA. Doesn't matter if you're a PA or a DO or an MD. If you know your crap, people respect you. First, when you get on the phone with them, they'll go, ugh, to talk to this PA. By the time you get off the phone with them, they're asking you if you want to work for them, okay? So here's the difference in the severity. We're going to take a quick break for 5 minutes, and then we will resume for the rest of the lecture. So I'm going to pause the video here. You guys take 5 minutes. Okay, you guys ready to go back to it?
Yep.
Okay, actually, give me just 1 sec. I got one more thing that I can't put on this recording. And then I'll have a case study for you. All right, we're back at it. Oops, I'm on Wesley scores. Okay, you guys see it?
Yeah.
Am I on the Wesley score when you look at it?
Yes.
Yeah, see, it's not gonna let me do it right now. Okay. So we talked about the Wesley score until we were blue in the face, but now we're on to influenza. So influenza, you're all pretty well familiar with influenza, right?
I have a question about the score.
Yeah.
So it says CROUP severity and treatment. So those two sections are not like adding up with the score on the right. Is it saying like if they have these symptoms or if they have that score, this is the treatment, or do they have to have both?
So what you do is you do each of those symptoms and you make a score. So like if their level of consciousness is disoriented, that's 5. Plus they're agitated, and when they get agitated, they get cyanotic, that's 9. If they have stridor at rest, that's 11. So now they're already at severe croup. See above 8?
Right, but on the other side of the chart, there's symptoms there also. And then the numbers beside it as far as severity.
Oh, that's a crappy chart, and it's not really giving you everything. So you have to use all the tables together to get the true Wesley score.
Okay, thanks.
Yeah. Yeah, because that's really not giving you the full story. Okay, can you guys see influenza on here?
Yes.
Okay, so influenza, commonly identified by the antigens, those little purple things on the virus itself, displayed on the surface of the virus. The people come in, they look like they've been hit by a truck. They feel like crap. Their symptoms are highly variable from GI symptoms all the way to cough, fever, sore throat, lymphadenopathy. Obviously highly contagious, primarily during the winter months, and can cause pneumonia, which can be a viral pneumonia, or they can get a secondary pneumonia, which is caused by a bacterial infection. The treatment is largely supportive. Fluids, right? We've all had the flus. It's like, oh, yeah, you got the flu. Okay, great, go home. You can use Tamiflu, right? Not highly effective. It reduces the duration of the flu symptoms by 8 hours and has a lot of side effects. Treatment's largely supportive. You can use steroids to reduce inflammation. You can also use bronchodilators to make the coughing more productive. You may hospitalize your high-risk groups like the elderly, and it may result in secondary pneumonia. Pertussis, also known as whooping cough, okay, caused by the bacterium Bordella pertussis. Okay, pertussis has these phases, but the main point of pertussis, oh look, I misspelled vomit. Awesome. But you are going to cough until you vomit. Okay, so basically that's how I diagnose in my adult population. If somebody's saying they're having post-tussive emesis, then that is highly indicative of a pertussis infection. So the phases here are always high yield because anything that is cumbersome and difficult to memorize is always high yield for boards. So there's this catarrhal phase, which is the initial phase, which kind of just presents like any other upper respiratory infection. And then the paroxysmal phase, which lasts for 2 to 3 months. Sucky. And then convalescent phase, which is the last couple weeks where it goes away. Treatment is primarily macrolides, so these people get the Z-Pack. We've been seeing some resistance. So generally, instead of the day 1 500 and then 250 each day after that, I'll give them 500 each day for 5 days. But whatever Thome is telling you is what's going to be on the test. Okay. Pertussis rates have drastically decreased since we began vaccinating. You can see that in the 90s there with the DTaP that we really started to decrease our numbers. Then the numbers started to creep back up, and now we give the booster. But also people are not vaccinating as much, and so we're seeing a rise and return of this nasty little bug. Pneumonia. So pneumonia here, basically exactly what it sounds like. You can dissect that term. So inflammation of the actual alveoli. So inflammation due to a viral or bacterial origin is the leading cause of death throughout the world. So basically you get this infectious process either from viral or bacterial origin, and you inflame the lung tissue, and the inflammation is actually driven by our own immune system, causing this war that's going on with either the bacterium or the virus. Causes for pneumonia: no pathogen is identified almost half of the time, but when we do get a nice sputum specimen and we get a culture, then we are seeing that primarily we're getting strep pneumo, then mycoplasma pneumoniae, then you've got your influenza A and B pneumonias, chlamydia pneumoniae, Haemophilus influenza, Legionella, parainfluenza, and then adenovirus. And somewhere near those adenovirus lives the coronavirus, okay? Not very common pathogen for pneumonia. All right, pneumonia characteristics. So they can have a day to 10 days of cough, fever, shortness of breath, increased heart rate, chest pain, chills, increased sputum production. They're sick, right? Physical exam is going to reveal some signs of crackles, maybe some consolidation suggestive of bronchi. They may have focal wheezing, and there could be dullness to percussion in certain locations secondary to consolidation. So as you do your thumping on the chest, if the sound changes in one area of the chest, that is suggestive of consolidation. You want to watch their vital signs because that's really going to show you the true story, with elevated temperature, decreased, and can be decreased as well. So sometimes older people will present with a low temperature rather than a high temperature. They can also have increased heart rate and increased respirations. Bacterial pneumonia, also known as community-acquired pneumonia in this particular setting, what we're talking about. There's also hospital-acquired pneumonia, which is a different topic altogether. So if it's acquired in the community, it follows certain patterns, it's treated certain ways because we're dealing with certain pathogens. If it's acquired in the hospital, generally these are resistant bugs, and so we got to bring out the big guns to take care of those. So the pathogen is not normally identified. Why? Because we prophylactically treat these people. We also don't usually get a very good sputum sample. And we don't always do a culture and take 10 days to tell them what they have, because then they'd be sicker than stink. Common pathogens are going to be your Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis, Staphylococcus aureus, and Klebsiella pneumoniae. Atypical pathogens, when people use the word atypical, it means that they're not typical, is Legionella, Mycoplasma, and Chlamydia. So Legionella, the key to Legionella is that it enjoys wet surfaces like ducting. So if you have some ducts that maybe you're having some sort of condensation inside of a ducting system, and the bacteria can proliferate up there and then push through the entire ductwork into the people's offices and everywhere else. That is one of the causes for Legionella. The reason why it is called Legionella is that there was a Legionnaire convention, and where all these people became infected with this pneumonia, and they were able to isolate the Legionella bacterium that really likes to live in the ductwork in these wet, moist environment and can cause infection that way. Mycoplasma, also known as walking pneumonia, and then chlamydia is another atypical pathogen. Here are some gram stains. These are some diagnostic studies, right? We want to do a sputum gram stain and culture. So up here you've got strep pneumoniae. Okay, strep pneumoniae, they call that because it's going to strep, the cocci kind of group together in chains, okay? Staph aureus is a staph because those colonies make little groups. Then you have Haemophilus influenza, Moraxella catarrhalis, Klebsiella pneumoniae, and Pseudomonas aeruginosa. So you're basically going from gram positive down to gram negative. The gram positives obviously are purple, and then your gram negatives are the red. Here is a sputum sample. It is sputum, not spit. We want people to make sure that this is coming from their feet. We're going to collect this and send it to the lab where the lab rats just love this stuff. They live and they play in this all day. And so they'll plate this up, they'll make a gram stain. They will grade the gram stain based on this criteria. How many epithelial cells are in it tells you as a clinician how good the sputum sample is. I don't want a lot of squamous epithelial cells because squamous epithelial cells live in the mouth. If I have a lot of squamous epithelial cells, then I have a crappy sputum with a bunch of contaminated bacteria. Bacteria that normally make up the flora that live in the mouth. I do not want that. I want the junk that is deep down in the lungs so that I get a good culture and I don't get crap. Crap in, crap out, okay? So they grade this right here. If there are a lot of neutrophils in there and there are, that would mean obviously white blood cells that are fighting the infection, so then they get a positive score. They get a negative score if there's a bunch of squamous epithelial cells. I want you to know so that you're not traumatized that this will not be on your test. I just want you to know that this is something that the lab rats are doing, and if you see this on a report, you'll be educated enough to know what's going on. All right, so let's talk about some diagnostics for our bacterial pneumonias. This is what we kind of alluded to before. So a lobar pneumonia, AKA lobar consolidation, right? So this is a right field lobe pneumonia. We've got consolidation in this lobe. And it is pretty obvious that there is not as much penetration of x-ray through that site because there's a bunch of pus and gunk in there causing the x-rays to be bounced back and not penetrate to the film. An infiltrate is not a lobar pneumonia. It is this small little infiltrate right there. They've got it circled. Now this is still treated like a pneumonia. However, it's not classified as a lobar pneumonia. So when you dictate on your chest films, you can say, chest film reveals a viral pattern with no signs of lobar pneumonia or infiltration. And then you sound smart, which is always good.
Hey, sir.
Yes.
Hey, can you go back one slide? How are you normally going to differentiate between that and a coin lesion?
So this is not, it does not have a well-defined border, and it does have a little bit of vascularity around it.
Okay.
So it's not super easy. I mean, that's why we also have radiologists, but the best differentiating feature would be their clinical presentation, right? So they're presenting with a URI, they're presenting like pneumonia, and they've got this infiltrate on chest x-ray. Now, a coin lesion is an infiltrate, right? It's just a more specific definition of that infiltration.
So infiltration is anything that is in the lungs that should not be there.
Basically, it's anything that's picking up x-rays and making it more opaque. Okay, air bronchogram. Now I think Hatch went over a bunch of this, but I just wanted to kind of bring it in again because there's not a lot of radiology that gets done. And then you get out into the ER and you're like, oh my God, what am I looking at? So an air bronchogram basically just shows that there's all this inflammation and infection, and then you can actually see in the bronchioles, which are not as inflamed as the alveolar tissue, you can see where the air is going in. And so that's what when you hear the term air bronchogram, this picture on the left is depicting where those air bronchograms are at. All right, a pleural effusion. So a pleural effusion is just a buildup of fluid within the lung. And we know that that's a buildup of fluid because this tissue has this meniscus type appearance here, like this. See how it's making that nice meniscus? Well, that's because the fluid is just pooling down here in this lung. And fluid's going to have some tension, surface tension, and it's going to make that meniscus shape. So that's a pleural effusion. That can come from a really bad, this would be like a lower lobe pneumonia, can cause all this effusion down underneath, okay? All right, so how do we manage these patients? Well, the majority of them are gonna get oral antibiotics and supportive care. The choices for drug, if they're a healthy person, and this is an outpatient setting, is a macrolide or doxycycline. If they're outpatient and they're unhealthy, it's going to be fluoroquinolone, a macrolide, or a beta-lactam. And when we go later today, we'll do some review, we'll do some questions, and I'll put a little bit more on hospital-acquired pneumonia, because I just realized that we don't have it in here. That's a pretty important topic. So let's talk about atypical pneumonias. So we've got most common being mycoplasma. This is your walking pneumonia. There's also viral, which would be considered atypical, chlamydia, Legionella, and MOCA, which we already kind of talked about. Presentation and management is actually very similar to the management and presentation with bacterial pneumonias, except it's just going to vary on what medications we use. So primarily we're going to use some azithromycin or doxycycline because we're suspecting that these bad actors are associated with this. And we can also use a tetracycline if we know that it's chlamydia. Who gets chlamydia?
Everyone.
So chlamydia
20
pneumonia is pretty rare. It's going to be in immunocompromised people, but you also want to think about this in people that take care of birds. Okay, what is the admission criteria for patients? So admission criteria is based on a lot of things. And if you work in an emergency room, you're going to get a bunch of pushback from the hospitalists. So you need to know your stuff. So you need to know how to get these people into the hospital, particularly if you think they need to be there and you should fight for them. So if their oxygen saturation is less than 88% on room air, it's a slam dunk. If you can prove that when they ambulate, it goes below 80%, it's a slam dunk. If they have a high SOFA score, it's a slam dunk. What's a SOFA score? It's how comfortable your couch is from a scale of 1 to 10. No, it's not. It is basically utilizing their comorbidities and coming up with a score that says, how likely is this patient to die in the next week or so? So I would recommend that sometime you look that up or just know that that exists, although it is not high yield for your current tests, so you may not want to do it right at this time. But just know when you go through your ER rotations and you get your handy dandy apps, you can calculate a SOFA score. So let's do that.
Hey,
If I'm
Tim,
going to use it, yes.
real quick, Amanda is having issues with her mic and she just asked a question. She said erythromycin or azithromycin for your previous slide? Because you said azithromycin, but it said erythromycin. She just wanted clarification.
Oh, I mean, they're pretty synonymous, right? You can use a macrolide. So you can use erythromycin. You can also use azithromycin.
Cool, thanks.
Okay, so let's get our calculator out and let's do our handy dandy conversion here. Trying to think if this is, I use MD Calc for this one. Plug for MD Calc. Whoop, whoop.
Yeah, so I was looking at that. Is it the one with the Q or the one without the Q? Because it gives you two options. Does it matter or no?
Let me get in there because I don't recall. SOFA score. In hospital mortality in non-ICU. Okay, yeah, so you want to use the Q SOFA score if you're trying to get them into the hospital.
Thank
So
you.
what you do is you say, here's the thingamajigger. Do they have an altered mental status? Yes. Is their respiratory rate greater than 22? Yes. Is their systolic blood pressure less than 100? No. Is this patient a COVID-19 patient? Let's see. Unlikely. Okay. SOFA score result 2 points. So they've got a high risk. So the lower the SOFA score, the higher the risk. So let's say they're not altered and they don't have a respiratory rate. Oh, I guess it isn't. So it's 0 was not high risk. It's basically, are they high risk to die or not? Identifies patients high risk for in-hospital mortality with suspected infection outside the ICU, okay? So you tell the hospitalist, hey, this guy's got a SOFA score of 2, and that's kind of how these hospitalists like to talk, so it's good to know that. Now, if you go to the other SOFA score, which is the main SOFA score, that is for inpatient, you've got to have a blood gas on them and an FiO2, and then tell them if they're on a ventilator. Then it takes into account what's their platelet count, what's their Glasgow coma scale, what's their bilirubin level, what's their pressure, and what's their creatinine, and then it tells you a SOFA score from there. So anyways, that's one. And then the other thing is, are they at risk for SIRS? So SIRS criteria is another thing. And when you use these words for the hospitalists, they're thinking money, right? And that money talks, baby. So you want to talk to them on their level. So you're like, hey, I don't know, this guy's, he's pretty crappy. He's got, signs of SIRS. So SIRS signs. So this is for SIRS. So we go temperature greater than 38. Yes. Heart rate over 90. Yes. Oxygen rate greater than 20. No. White blood cells greater than 12,000. Let's say yes. Suspected or present source of infection. Yes. Okay. This is our person with pneumonia. Do they have a lactic acidosis? Let's say no. Severe hypotension? No. Evidence of 2 organs failing? No. Suspected COVID-19? Let's say unlikely. And this patient meets sepsis criteria. So when we add that into our oral report, we're just speaking their language, okay? We're automatically getting some props, although be it in the back of their mind and they still don't like us, we at least are respected, okay? So we want to use those scores when we talk to other professionals so that we get some respect from the get, all right? Altered mental status is another criteria for admission, and then obviously any vital sign changes. Let's talk about procalcitonin. So what the heck is procalcitonin? Well, here it is in the really scientific way of expressing it. But basically, procalcitonin is a signal molecule that signals to the body when there is a bacterial infection. It's elevated during systemic inflammation, and particularly with bacterial inflammation, okay? And so what they do, what I do, and all the good studies have been done on pulmonary pathogens. So if you get a procal also on these people, then they really can't buck you because you're like, hey, this guy's got a procal, over 0.5. He's got signs and symptoms of pneumonia. He's kind of borderline hypoxic. So say somebody's satting over 88%, but you still want to get him in the hospital, well, throw ProCal on there and, you know, maybe that'll work for you. But at any rate, when you get that procalcitonin, maybe you'll just get it for the patients you know that you're going to admit, because the hospitalist will get this also. What they're monitoring is the patient's response to antibiotic. So their ProCal's like 1.0, but you give them antibiotic and now it's dropping. Then you can decide when you want to quit giving the patient antibiotics based on their procalcitonin. So here's like a little decision-making rule for procalcitonin. So if somebody presents with lower respiratory tract infection, less than 0.1, antibiotic is strongly discouraged. But then once you get to your 0.5s and above, then antibiotic therapy is strongly encouraged. So if you're using these modalities, you're using the ProCal to dictate what you're doing and how concerned you are about a patient, you're doing your due diligence. Good. Okay. So when we talk about risk factors and pathogens, we need to know which risk factors are associated with risk factors. I'm going to put out some little cheat sheets for you guys today. So I've got these pulmonary pathogen, infectious disease cheat sheets, which you'll get the masters so that you can just use them for study guide over the weekend, but they're really good. I mean, they really hammer home all these infectious diseases. They put it in one clear spot, and they even add things on here that this lecture doesn't completely cover, because like you guys said, this is a really broad topic. There's a whole lot of overlap, and sometimes it's difficult to be like, okay, how do I know if it's this and who gets that? And these little guides are really helpful to that. And I don't think you have to remake the wheel. I'll just send them out to you so that you have them and you can use them as a study guide. Okay, so long story short, alcoholics are more prone to Klebsiella pneumonia infections. Let's see if we've got it on our little handy dandy chart here. One of them talks about alcoholism, and I'm sure it's the Klebsiella. If I can just find Klebsiella. Yeah, Klebsiella, dark, mucoid, current jelly, sputum. Alcoholism is your risk factor there. Okay, so smoking, more prone to Pseudomonas. Okay, lung abscesses, more prone to fungal infections. HIV, more prone to Pneumocystis jivaericii. Influenza can cause secondary infections of Staph aureus and Strep pneumoniae. Coughing greater than 2 weeks is consistent with pertussis. If they do that whooping cough thing, then you really know, or they say I'm puking after I cough, then you really got a good idea. HIV, so HIV is a bad actor, right? HIV causes your immune system to malfunction. So these people are prone to infections that the other people in our population don't ever even experience. So they're more prone to bacterial infections, and they're more prone to fungal infections. They can be targeted by these opportunistic infections, meaning that this Pneumocystis jivaericii is all over, it's ubiquitous. But if your immune system is not functioning correctly, this thing can flourish, okay? Also, Haemophilus influenza, Pseudomonas, Mycobacterium, okay? So much overlap. The main one that you really need to take home is this, Pneumocystis, okay? Because that's the key factor. Nobody else gets pneumocystis except these guys, okay? All right, so lymphopenia, what the heck does that mean, right? Just low lymphocyte count. All right, you want to get a sputum to guide their treatment because these guys are at high risk of decompensating on you, and you can prophylactically cover them with trimethoprim sulfamethoxazole, which definitely covers pneumocystis. All right, viral pneumonia. So a viral pneumonia, not going to show you this nice, beautiful pneumonia. They're harder to look at. they're just kind of like, boy, there's like patchy crap all over that x-ray. That's a viral pattern. So you sound really smart if you say, oh, but you know, there's a viral pattern on x-ray. Oh, his procal's, you know, 1.0. Now that sounds confusing, right? Because I talked about bacterial infections with procal, but a severe viral infection can also cause it. So the nice thing about some of these viruses is we can do some rapid testing for them, but the treatment is not brain surgery. It's largely supportive. We want to make sure that they're hydrated. We can put them on antivirals. We want to identify the cause. Was it influenza, RSV, adenovirus, parainfluenza, or now coronavirus? Which these coronaviruses were usually just ubiquitous viruses, but now we're deciding to find them all over. So we're finding them more often. Okay, fungal pneumonia. Aspergillus, cystic fibrosis patients are more prone to this infection, and all immunocompromised patients. So AIDS patients, HIV patients also get this. It causes a severe necrotizing pneumonia. That is a nasty plain film, okay? That is not what you want to see on a plain film for your patient, okay? Another fungal pneumonia is histoplasmosis, usually caused or found in children with bad lungs, people who are immunocompromised, or people that live around soil that have a lot of bat and bird droppings. Also, histoplasmosis, you want to extrapolate that. Say, okay, bat droppings. Who really likes bat droppings? Well, people that go spelunking, they like bat droppings because they're in caves where bats live. So your spelunkers might be more prone to having a histoplasmosis infection. So if Cody comes to me and says, hey dude, I've got this bad infection, I've got this fever, and I was recently spelunking, looking at the stalactites and the stalagmites, and now I've got this infection, and my bird keeps pooping on my floor, then I know that I want to think about histoplasmosis. Coccidioides mycosis, coccidiomycosis is also known as valley fever. It is endemic to the California and the southwestern areas. It is a spore-forming fungal organism that these spores will lay dormant for years. So in dry times, they just chill. And when it rains, then they make these moldy spores, and the spores fly into the air and they infect you. So if somebody says, oh, I come from the, Columbia, whatever, the California, I forget where it is, but down in California or South America or the Southwest, then you want to kind of keep in the back of your mind this valley fever. All right, tuberculosis. So we don't see a lot of tuberculosis, but we can see it in immunocompromised patients or patients that have recently relocated from other countries and may have not been vaccinated, or there's some sort of environment that is more prone to infection, or there's persons in that region that it's endemic to the area, and they may be more likely to be either latent carriers or actually have active TB. So tuberculosis is a mycobacterium species. They're really hard to kill because they have this nice coating around them, and they can kind of encapsulate themselves, hide themselves from the antibiotics, and then come back out and flourish. The majority of us, we probably are exposed to this, especially for healthcare workers, probably come and gone. But most of us, 90% of us, are not going to develop an infection. 10% will develop primary TB, and then they will not progress to active TB, and then the other 5% will develop active TB. Clinical features include coughing, 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 and more coughing, fever, night sweats, and anorexia, which leads to weight loss, okay? So that's why when you do your review of systems, you say, any fever, any night sweats, any weight loss? Okay, that's screening for badness. We're looking for malignancy, tuberculosis, HIV, some sort of weirdness, some sort of pathology that we need to further investigate. Here's the x-ray. So on x-ray, you can see bilateral hilar lymphadenopathy. Okay, that is not normal. That is actually not a parahilar pneumonia. Those are the lymph nodes in the hilar region that are super inflamed. Okay, that is considered bilateral parahilar lymphadenopathy. Also, you can see these granulomas. So this is seen on a patient that does not have active TB. That is right there. That is granuloma. Okay. So I'm going to defer to Joel on the treatment because I went round and round and round with this, and I thought, you know what? Joel loves this stuff, so I'm just going to let him do it. So anyway, defer to Joel, but I added these on here just in case you guys are psychotic and you want some extra work to do. That is it. Do you guys have any questions? Anyone? Anyone?
I just wanted to say that you spelled vomit correct.
I did?
Yeah.
Oh, well, thanks.
It's surprising
Sure did.
that you did it.
Well, I'm usually such a bad speller that I thought maybe I did. All right. Well, I'm going to stop the recording. Now you can ask me some real questions.